Hello everyone and welcome back to the channel. If you have rheumatoid arthritis and treatments such as methotrexate haven't controlled your disease adequately, you may eventually be offered something called a JAK inhibitor. These are some of the most interesting treatments we've introduced into rheumatology because unlike biologic medications that are usually given by injection or infusion, JAK inhibitors are tablets. They can be highly effective and may work relatively quickly. But you may also have heard concerns about infections, shingles, blood clots, cardiovascular problems, and cancer. So, how do these medications actually work? How effective are they? And why might your rheumatologist choose a JAK inhibitor rather than a biologic? I'm Dr. Naveen Bhadauria, consultant rheumatologist at Pure Rheumatology London, and today I'm going to explain exactly what you need to know. Let's start with the name. JAK stands for Janus kinase. Your immune system communicates through chemical messengers called cytokines. In rheumatoid arthritis, some of these inflammatory signals become overactive, contributing to joint pain, swelling, morning stiffness, and, if inadequately controlled, joint damage. Many of these signals communicate through a system inside our cells called the JAK-STAT pathway. You don't need to remember the science. Imagine an inflammatory messenger arriving at the surface of a cell and delivering an instruction. JAK proteins help transmit that message from the surface of the cell towards its nucleus. A JAK inhibitor interrupts parts of that signaling process, reducing the effect of several inflammatory pathways. JAK inhibitors are therefore known as targeted synthetic DMARDs or disease-modifying anti-rheumatic drugs. Examples used for rheumatoid arthritis include Tofacitinib, Baricitinib, Upadacitinib, and Filgotinib, although which drugs are available and appropriate depends on local licensing and individual circumstances. Now, one of the questions patients often ask me, is a JAK inhibitor basically a biologic in tablet form? Not exactly. Biologics are generally large protein molecules designed to target particular parts of the immune system. Anti-TNF drugs, for example, target an inflammatory cytokine called tumor necrosis factor or TNF. Because biologics are proteins, most can't simply be swallowed as tablets because they will be broken down in the digestive system. That's why they're usually given by injection or infusion. JAK inhibitors are much smaller molecules. They can be absorbed through the digestive system, so you can take them as tablets. And rather than targeting one cytokine outside the cell, they interfere with intracellular signaling used by several cytokines. For patients who don't like injections, that can be a major attraction. But convenience isn't the main reason we prescribe them. The most important question is, do they actually work? And the answer is yes. JAK inhibitors can be very effective treatments for rheumatoid arthritis. Clinical trials have shown improvements in painful and swollen joints, morning stiffness, physical function, and overall disease activity. Some patients can achieve low disease activity or remission. Another interesting feature is that they can sometimes work relatively quickly. Some patients notice improvement within the first few weeks, although everybody responds differently. So if these are effective medications taken as tablets and potentially fast-acting, why don't we give them to everyone? Because choosing rheumatoid arthritis treatment isn't simply about finding the most powerful drug. It's about finding the treatment with the right balance between benefit and risk for that particular patient. And this is especially important with JAK inhibitors. One study you may hear about is the oral surveillance trial, which investigated Tofacitinib in patients with rheumatoid arthritis aged 50 or older who also had at least one cardiovascular risk factor. Compared with TNF inhibitors, the trial raised concerns about an increased risk of major cardiovascular events and malignancy, and JAK inhibitors have also been associated with venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism. These findings led regulators and rheumatologists to become more selective about how JAK inhibitors are used. This does not mean JAK inhibitors are dangerous for everyone. It means that before prescribing one, we need to understand the individual patient's risk. For example, I want to know, do they smoke or have they smoked for many years? Have they previously had a heart attack or stroke? Do they have significant cardiovascular risk factors? Have they previously had a DVT or pulmonary embolism? Have they had cancer? How old are they? And are there other suitable treatments available? This is why two people with apparently identical rheumatoid arthritis may be offered completely different treatments. One might be younger, a non-smoker with no cardiovascular disease and no history of thrombosis. Another may be older, have a significant smoking history, established cardiovascular disease, and a previous blood clot. The arthritis might look similar, but their overall risk profiles are very different. That's personalized medicine. Another important consideration is infection. JAK inhibitors suppress specific parts of the immune response, which can increase the risk of infection. Before treatment, patients are normally assessed for important infections such as tuberculosis and viral hepatitis according to appropriate protocols. One infection particularly associated with JAK inhibitors is shingles or herpes zoster. Shingles occurs when the virus that causes chickenpox, which can remain dormant in the body for many years, reactivates. JAK inhibitors can increase that risk, so vaccination status is something we should consider when planning treatment. We also perform regular blood tests. Depending on the particular medication, we monitor things such as your blood count and liver function, and JAK inhibitors can also affect lipid levels, including cholesterol. Again, that doesn't automatically mean the medication needs to be stopped. It means we need to monitor you appropriately and manage cardiovascular risk as part of your overall treatment. Another question I often hear is, are JAK inhibitors better than biologics? There's no simple answer. Both can be highly effective. Some JAK inhibitors have shown impressive efficacy in clinical trials, including studies comparing them with other active rheumatoid arthritis treatments, but effectiveness is only one part of the decision. For one patient, an anti-TNF biologic might be ideal. For another, a biologic targeting a different pathway may be preferable. And for another, a JAK inhibitor may offer an excellent combination of effectiveness, convenience, and suitability. That's one of the great advances in modern rheumatology. We now have choices. 20 or 30 years ago, treatment options for severe rheumatoid arthritis were much more limited. Today, if methotrexate doesn't control the disease adequately, we have multiple biologic therapies and targeted treatments working through different mechanisms. And our goal isn't simply to make your joints slightly less painful. Our aim is remission or very low disease activity, preventing joint damage and allowing you to live as normally as possible. One final area worth mentioning is pregnancy. JAK inhibitors are generally not treatments we use during pregnancy or breastfeeding. So if you're planning a pregnancy, it's important to discuss this with your rheumatology team in advance. There are other rheumatoid arthritis medications for which we have much more reassuring pregnancy safety data. So what should you remember about JAK inhibitors? Firstly, they're effective targeted treatments for rheumatoid arthritis, and unlike biologics, they're taken orally. Secondly, they can sometimes work relatively quickly and may provide excellent disease control. Thirdly, they're not automatically better or worse than biologics. The right choice depends on the individual patient. Fourthly, there are important risks we consider, particularly infection, shingles, cardiovascular events, blood clots, and malignancy, and those risks may be more relevant in certain groups of patients. And finally, don't be frightened simply because you've read a long list of potential side effects. Every effective medication has benefits and risks. The important question is whether the expected benefit outweighs the risk for you. JAK inhibitors are a great example of how much rheumatoid arthritis treatment has evolved. We now have highly targeted treatments that can control disease in patients who previously had relatively few options. And the future of rheumatoid arthritis treatment is increasingly about choosing the right medication for the right patient at the right time. If you found this video useful, please give it a like, subscribe to the channel, and share it with somebody living with rheumatoid arthritis. And if you'd like me to make a video comparing JAK inhibitors versus biologics, including how rheumatologists decide between the two, let me know in the comments. Thank you very much for watching. Take care, and I'll see you in the next video.